Hello everybody and welcome to this latest panel discussion from the Underwood Center for Digestive Health at Houston Methodist Hospital. My name is Eamonn Quigley and I serve as co-director of the Lynda K and David M. Underwood Center for Digestive Health at Houston Methodist Hospital. It's a great pleasure to welcome you today to what I think is a very special and very timely roundtable about a topic that I think is of interest to everybody, namely obesity and weight loss. Today we're going to talk about the whole spectrum of management of obesity and excess weight, everything from diet to endoscopic approaches to surgery. And also, of course, the topic which has really changed the whole scenario here, namely the availability of these GLP-1 agonists. We have a wonderful panel assembled, including experts from Houston Methodist Hospital. We're also joined by Dr. Chris Thompson from the Brigham and Women's Hospital and Harvard Medical School. And all of these individuals bring their own perspective. It could be surgical, it could be endoscopic, it could be medical, and also their expertise and experience over many years of managing these issues. So at this stage, I'm going to go around and ask everybody to introduce themselves, starting with Dr. Thompson.
Thank you. I'm Dr. Chris Thompson from Harvard Medical School. I'm a professor here at Harvard, and I'm also the director of endoscopy at Brigham and Women's Hospital, where I'm also the co-director for the Center of Weight Management and Wellness. And I've been working on bariatric endoscopic therapies for nearly 20 years now, and I'm very happy to be part of this panel. Looking forward to the discussion.
Thank you very much, Chris. Great to have you with us. Dr. Ali?
Hi, I'm Dr. Aman Ali. I'm a bariatric and foregut surgeon. I'm also the director of obesity medicine here. I practice a whole range of therapies for obesity, including behavioral, medical, endoscopic, and surgical. Happy to be here. Thank you for inviting me.
Hi, I'm Thomas McCarty. I'm an assistant professor of gastroenterology. I'm an interventional endoscopist and bariatric endoscopist here at Houston Methodist, with a unique background in interventional procedures and bariatric endoscopy. So thank you so much for having me today.
So as I mentioned in the introduction, this has become a rapidly changing area. Years ago, we just had weight management in terms of diet and some medications, a lot of which had a lot of side effects. And then we moved into the surgical era. And now, of course, we're moving into the endoscopic surgical era. And then out of the blue almost have come the GLP-1 agonists, which have really changed the whole field. So we'd like to touch on each of those areas as we go around, but I'd like to start by asking each of our panelists to give a brief introduction to their area. And I'd like to start with Dr. McCarty and ask him to give his view of the current landscape and, of course, the impact that GLP-1 agonists have had on the field.
Yeah, so thank you so much. So GLP-1 agonists have really become ubiquitous in popular culture. And we've seen a dramatic increase in the popularity of these treatments, as well as the interest from individuals across the board who are seeking durable treatments for obesity. If we view obesity as a chronic disease model, these GLP-1 medications in some form or fashion have been around for about 10 years. And we mentioned they're become ubiquitous. About 1 in 8 of Americans in the U.S. have actually tried one of these medicines. And when we're talking about these GLP-1 agonists or GLP-1 GIP agonists, we're talking mostly about semaglutide or tirzepatide. There are some older generations like liraglutide, but the main ones we're talking about today are these newer ones, the semaglutide and tirzepatide. And really, these have changed the landscape of traditional treatment of obesity. From oral medications like Dr. Quigley mentioned, like phentermine, which was FDA approved in 1969, to these more sort of injectable medications, which have really seen remarkable weight loss numbers. And so if you look at the literature, the randomized controlled trials, really the step 1 studies, these medications are getting upwards of 20 to 21% total body weight loss. And while we know that this real world data is probably a little bit less, it's quite powerful compared to the 5 to 10% we used to get with these oral medications, even at best. So they've really seen a really big interest from patients who are interested in weight loss medicines. Now, it'd be remiss to not talk about potential side effects with these medications. Again, they're not right for everyone, which I think we'll have a spirited debate about. But some of these medications, about 30 to 40% of patients will have GI side effects. And the real world data has really shown that about 50% of these patients end up discontinuing them at 1 year, either because of difficulty with medical coverage or insurance coverage, or these side effects that we'll get into a little bit more. But I think overall, these medications are a fantastic tool in the armamentarium or our treatment for obesity, and definitely have a role, which we'll delve into a little bit more in just a bit.
So, Dr. Thompson, I think you are rightly regarded as the father of endobariatrics. Could you tell us how this field has evolved, how you got involved in it yourself, and how you've seen it progress over your illustrious career?
Sure. Well, thank you. I really started working on these procedures back in 2003. So I was just finishing fellowship, and we were seeing a lot of surgical complications back then, especially in patients that needed revision procedures. So they had a gastric bypass and they needed to be converted or revised due to weight gain or fistula or some other reason. And those procedures are very technically demanding. And this is over 20 years ago, obviously, and it was challenging. So we were seeing a good number of complications. Right about that same time, there was a suturing device that was developed by the Bard company called the Bard Endocinch. It was meant to be used for treating heartburn. So it was an anti-reflux device. And the idea just kind of came to me that we could probably use that, push it down a little bit farther, and start addressing some of these, these complications of the bariatric surgery, starting with gastric fistula. That was really the first case that we did, and then we started making outlets smaller. We did some background research, and we found that the size of the gastrojejunal anastomosis actually was important for weight regain or recurrence of weight gain. It wasn't so much important in the initial weight loss, but as far as weight gain, it was very important, independent predictor. So we started making those smaller with the device, and then that was a natural bridge into primary therapies. So I think it really came about just because being an interventional endoscopist and seeing those complications, thinking that there had to be maybe a less invasive way to help these people out.
Now, along the way, some procedures fell by the wayside and others actually have stood the test of time. What has really determined which succeeded and which have, as I said, been cast to the wayside?
Well, it's interesting. Not necessarily the device or the efficacy of the device. It's a lot of times timing, FDA kind of interest. I think that early on, the first devices were inferior for suturing because they weren't full thickness. So those were only suturing into the submucosal layers, and certainly those devices they wouldn't stand the test of time because they didn't deliver durable results, right? So you place the stitches in there, they do great for 3, maybe even 6 months, and then the stitches would all fall out. There wasn't enough time to remodel anything really permanently, and they gained their weight back. So I think that element of the device, the inability to place these stitches into the muscle layer and kind of be more permanent, was why those disappeared. I think the early balloons disappeared because they were, they had issues with seams that would rub in the stomach. And so that would be related to ulcerations and other complications, a lot of discomfort. And so those also might break down and migrate more often. So the early balloons had issues as well. Those go way back into the 80s, actually, with the Edwards Guerin bubble and whatnot. So those devices did have some critical flaws, but they were certainly instrumental in showing there was an efficacy signal that encouraged other companies, other startups to explore the space. And I think that was great. Now, there was another device that I think worked quite well, as a TOGA device. And that actually met their endpoints for FDA clearance, but it was kind of at the time of the notes, natural orifice transluminal endoscopic surgery, and there was a lot of skepticism on these procedures, and the FDA at that point kind of transitioned and said, no, we need to change our studies. We have to do more rigorous PMAs. And even though it had kind of met its endpoint, the goalposts were moved after the fact, and that device, failed not because of bad outcomes. It was just because of the regulatory environment changing. So I think there's a lot of moving parts here between the regulatory environment, safety concerns and efficacy that have impacted various devices. But now we do have a good head of steam, and I think that we're going to see more devices getting through the FDA and becoming available to patients in the near future.
Now, Dr. Ali, I think we could say the same thing about the evolution of surgery over the last 20 or 30 years. In other words, some procedures have stood the test of time, others have come and gone. So how have you seen the evolution of surgical approaches to obesity?
I think we have the most amount of data from the surgical world in terms of obesity with weight loss therapy. If you look at all the way back to the 1970s, when we were doing gastric bypasses, we did notice that all of our patients after surgery, within a couple of days, had a surge of GLP-1. And that investigation now led to all the development of the GLP-1s that we have right now.
Mm-hmm.
So post-surgery, whether it's sleeve or gastric bypasses, you see this increase in GLP-1s. There's other procedures that were previously popular, like the vertical banded gastroplasty, or even the laparoscopic adjustable gastric band, which are still performed today, but nowhere close to the same volume as it was before, because we're finding that a restrictive component to the stomach is not the only way to lose weight, and it's not the most efficacious way to lose weight. There's also a neurohormonal component and a malabsorptive component that plays a big role. And I try to explain that to my patients when they come, that obesity, that being obese is not a trait, but it's a medical condition. And the diagnosis of obesity is complex with complex pathophysiology, and sometimes you need multiple modalities of treatment. And at the foundation of all this treatment is behavioral modification. And then when you have good behavioral habits, including diet and exercise, everything else builds on top of it, including medical management, endoscopic with Endo-Bariatrics with Dr. Chris Thompson and Dr. McCarty mentioned, and then surgery as well. As we've gone forward in time, now the most popular procedures, still the number one is sleeve gastrectomy. Second is Roux-en-Y gastric bypass. We've started doing more single anastomosis duodenal bypass or SADY procedures. And then a lot of our revisional cases include like limb lengthening or gastrojejunal anastomosis. And in my practice, I do a lot of TOR procedures as well that Dr. Chris Thompson mentioned, that going with the approach of an endoscopic way, sometimes it's more feasible and less risky for complex revisional surgery.
Now, one of the things that I've noticed over the last several years is the relative disappearance of the vertical banded gastroplasty and the adjustable sleeve, and the growth in popularity of the new gastric sleeve procedure. Has that become the most popular procedure now, and why is that the case? Is it because it's technically easier, or?
Yeah, so I think when you have a foreign body placed inside your abdomen for a very long time, it creates an inflammatory reaction, creates scar tissue. Over time, even after you remove the band, that scar tissue causes a constrictive effect, and people have a lot of GI motility issues with proximal dilation of their proximal gastric pouch, even their esophagus, which leads to dysphagia. The complications from these bands, they could be erosion, perforation. There's so many out there. At the time when we were placing them in about 10, 20 years ago, they were the procedure of choice at that time due to the technology that was available. But now, through minimally invasive approaches, robotically or laparoscopically, we can do a lot more advanced procedures without doing an exploratory laparotomy on obese people. That's very difficult to do. So,
and I address this question to all of you. Would it be fair to say that in terms of these interventions, that the Roux-en-Y gastric bypass has set the bar in terms of outcome, in terms of weight loss, and in terms of metabolic outcomes?
So the Roux-en-Y gastric bypass has probably the most data that's long-term in terms of diabetes resolution, in terms of weight loss, in terms of complication outlooks and everything. I would argue that there's other procedures that are now available, such as the single anastomosis duodenal ileal bypass, that do have higher rates of type 2 diabetes remission, higher rates of weight loss. Compared to even SADY, the duodenal switch is even higher, but it has more malabsorptive components, which leads to nutritional deficiencies. So I feel like the SADY S is like a mediator where patients that really require it, that don't have terrible reflux, that is a good procedure for them.
Would you just mind describing that procedure in a little bit more detail?
Sure. A SADS procedure is the patient gets a sleeve gastrectomy, and then right at the beyond the pylorus, about 3 centimeters, we transect the duodenum, and we attach the duodenum to the ileum. The main thing that we're looking at is the common channel of what portion of the intestine receives both the digestive enzymes and the food through the alimentary tract. And we want the common channel to be around 250 centimeters to 300 centimeters, whereas previously for the duodenal switch, it was close to about 100, 150. Now, having a longer biliopancreatic limb gives the patients more of a metabolic effect and benefit, making their bodies more sensitive to insulin. Studies have shown that there's a higher GLP-1 response as well. But because of this SADS procedure, patients are not only losing weight, but they're having a lot of their metabolic conditions improve as well.
And that's become a very important outcome for all these procedures. So, Dr. Thompson, given the, as Dr. McCarty said, the ubiquity of GLP-1s, the changes that we've heard about in terms of surgery, where now does endoscopic therapy fit in?
Well, I think that, GLP-1s have been very helpful in many ways because, as Dr. McCarty mentioned, many people have tried these, right? 1 in 8. There's ever increasing numbers of people that are trying them, and most of them don't succeed, right? Long term, they're going to have issues, and you can get into all the problems with GLP-1s. But he mentioned intolerance, whether it's GI intolerance, nausea, vomiting, other things. Cost, they're very expensive, so people will not want to stand them long term, potentially due to cost limitations. But what you see with these is you can kind of induce a bit of sarcopenia. So people will lose, say 1/3 of the weight they lose is going to be lean mass. So that's a rough number. They're trying to improve that, but with the Ozempic, that's about what you're getting, right? So if you lose 10 pounds, you're going to lose 3 pounds of muscle. And you do a couple of cycles where you go on and off of this, and next time lose another 10 pounds, and you'll lose another 3 pounds of muscle. You're not going to put your muscle back on. Okay, it's very hard to put on 6 pounds of muscle or 10 pounds of muscle, but you'll put your fat back on. So you're having a shift in your body composition is something that's not favorable. So people realize this, they eventually kind of catch on to what's happening. And so the ones that are getting caught in that, again, the majority of people are going to have some issue with the GLP-1s. It gets them in the system, right? So now they're in the system, and these people might not otherwise have been in the system seeking help for their obesity. So now they start looking at less invasive alternatives, and many are turning to our endoscopic therapies. As a matter of fact, over 70% of the people that come to us for procedures have already tried and not been successful on GLP-1 medications. So I think it's been great because the people that it helps them, they do great, and that's wonderful. And then the people that it doesn't help, it helps them kind of indirectly because it gets them in the system, and they're open-minded to seeking alternative therapies.
Now, you mentioned complications earlier, Dr. McCarty. It's not very common, but one of the complications that's hit the press a lot recently are the question of eye problems. Yeah. So tell us what's going on there.
Yeah, so there's a sort of a retrospective study that showed that these GLP-1 agonists and mostly GLP-1 agonists have an increased risk potentially, or an increased association with optic neuritis. Specifically among diabetics. Now, there are some studies that show that optic neuritis risk or association with diabetes not on these medicines is about sort of 3 to 5%, but that risk appears to be almost triple, at least an association potentially on these. Now, that really hasn't been borne out in any sort of high quality studies, so I would say we don't have enough literature to definitively sort of make this statement. But Dr. Thompson brought up a good point, which we hadn't yet talked about, which is cost. And so while these drugs are very, very good, and even for the right patient who doesn't have side effects, we really start these medications with the idea that they're started indefinitely, right? And so the idea is that you're on these medications lifelong, especially when we think about obesity as a chronic disease. And so with the significant cost, especially if you're paying out of pocket or even partially insurance coverage, these medications become quite expensive to a healthcare system that already has problems with spending. And so, like we said, endoscopic options and bariatric surgery even become much, much more cost effective. And Dr. Thompson actually published a study on this showing that for class 1 and class 2 obesity, endoscopic options tend to be more cost effective compared to these GLP-1 agonists, especially at the current price. And another study showed for class 3 obesity, bariatric surgery is by far the most cost effective.
So, Dr. Ali, you mentioned, and I know you've spoken of this elsewhere, the importance of the comprehensive approach going for every patient. So tell us a little bit more about exactly how you achieve this comprehensive approach.
Sure. So when a patient comes to my clinic for weight loss, we first classify how much obesity they have. And right now, obesity, the diagnosis is based on BMI, but for me, I don't think that's a good indicator. So every patient that walks through my clinic gets a body composition.
No, it's taken me 30 years to learn how to calculate BMI, so I hope you're not going to change it.
So BMI for patients that have a lot of muscle, like Dr. Thompson mentioned, that is a really intricate part of the equation that I initially use for not just having the patients lose weight, but to maintain the weight loss in the long term, right? So when all these patients come in, I calculate the FMI, their visceral adiposity, their body composition in terms of fat mass.
So much more comprehensive
assessment. Yeah. The patients normally spend an hour with me in their first visit. And then I lay down their percentages in terms of weight loss. With behavioral weight loss, about 3 to 5%. With medical weight loss, if it's a single receptor like semaglutide, about 15% total body weight loss, whereas the trizepatide would be about 20% body weight loss. And then comes the Endo-Bariatrics procedures, where we have ESGs with 45% excess weight loss, whereas we have sleeve with 60% excess weight loss, with bypass would be 70, and then with SADI it would be 80% excess weight loss. So we calculate all of these, and I actually give them a hard number of the projected weight loss for each of these modalities. Once I do that, I have patients that are excess of BMI 50, 55. One therapy is not enough. And literature shows that if you have a patient over 50, sometimes you need a combination of therapies. For me, as a surgeon, I want to make the surgery as easy as possible for me, and whether that's endo-bariatrics or whether that's a surgical approach. And sometimes I even start GLP-1s preoperatively or pre-procedure. And I can get a BMI 70 patient to maybe a BMI 50, which makes the patient decrease their perioperative complications substantially. And then after the procedure is done, I use it again afterwards too. So I feel like it's another tool that we have in our tool bag now that we didn't have before. So I'm thankful that the GLP-1 drugs are there, but I also caution the patient that whenever they do lose weight, I focus so much on weight-resistant exercises postoperatively because I worry so much about sarcopenia, and I don't want these patients to have weight regain 2 or 3 years later.
Yeah, so this, as Dr. Thompson also mentioned, sarcopenia has become an important topic in this area. So, Dr. Thompson, you mentioned an important issue, which was some people don't do well on GLP-1, and you mentioned one reason, which is that they are intolerant. Are people actually resistant to GLP-1 agonists?
Well, we think so, and it's hard to know exactly, why that might be. We know that it doesn't durably kind of reset or alter the metabolic set point. So for everybody, when you go off them, you're going to gain weight. So we know that that's consistent. So you need a game plan for afterwards, because when you stop them, your body's set point has not been adjusted and you'll regain weight. There was a interesting study from Blue Cross where they looked at actually real world data on use of these things. And I think it was 30% discontinued at 1 month. Okay. And this isn't due to cost. There was another study that looked at that was published in JAMA Network Meta. And I think it was the 58% had discontinued it by 12 weeks. So, there's seriously some issues there. And then when they looked into why they were discontinuing them, it was quite interesting. It was either they weren't having a weight loss effect. That was the number one thing. It wasn't that they did well, because the original concern was, they just stopped the medications because they worked so well. No. So in the JAMA paper, they found out that actually they were stopping them by and large because they didn't work well, right? Or they had some GI side effects. So clearly there's some resistance there, and it's not clear exactly, exactly what that is yet. But there's several studies that are looking into it to try to parse out, why people don't respond separate from those side effects.
Is this something you've seen in your practice, Dr. McCarty?
Yeah, I would say we have pretty good data that shows that these drugs you get less weight loss among patients with diabetes. So that's been pretty bore out in the literature.
Right.
Now, as to what the exact mechanism is, we don't quite know yet. But I would say among patients with diabetes, they tend to have inferior weight loss outcomes than those who are non-diabetics. You did bring up a good point about weight regain. There was a nice post hoc analysis even of the STEP 1 trial for semaglutide, which showed a significant amount of weight regain once these drugs are stopped. And these patients were followed for 2 years and stopped at 1 year. And a large percentage of patients regained a significant portion of weight. And we've talked about what that weight entails. It's probably mostly fat reaccumulation. Yeah. But I would say where I think we've had success, and kind of Dr. Ali mentioned this, is in combination therapy. And if we're able to alter the anatomy, either endoscopically with an endoscopic sleeve gastroplasty or with a bariatric surgery, be it a sleeve gastrectomy or a room-wide gastric bypass, that risk for weight regain, because the anatomy is now altered, is much less. So I think that's really the key, especially for patients who are on combination or dual modality therapy.
No, I want to expand the discussion a little bit, because right from the get-go, I think all of you mentioned that obesity is a disease process. It's a complex disease. It's not just weight. You've got to talk about diabetes. You've got to talk about non-alcoholic fatty liver disease, or they now call it metabolic associated fatty liver disease, and several other complications. So I think one of the interesting things that I've noticed in the literature is that the literature has kind of moved away from just talking about excess weight loss or how much body weight would actually impact on these metabolic complications. And I think that's where these are really being tested. So you actually brought up the topic of diabetes, Dr. McCarty. How, if you look from GLP-1 through endobariatrics to surgery, how good are they at addressing diabetes or fatty liver or these other complications?
Yeah, great question. And I think that's really where the field is going, right? We want to see improvements beyond a number in the scale. We want to see improvements in comorbidities. And I would say the best literature, as Dr. Ali said, is from room-wide gastric bypass, which is really the gold standard and what we measure everything. Yes, is what we measure everything against. Yes. So if we're looking to improve diabetes, room-wide gastric bypass is probably the most commonly performed procedure. Obviously, duodenal switch, SADE can get excellent numbers, probably even more impressive numbers, but really the bar is set at room-wide gastric bypass. Now we have quite good data, long-term data, 10-year data for ESG, which is the endoscopic sleeve gastroplasty that shows improvement in comorbidities like obstructive sleep apnea, blood pressure, dyslipidemia, diabetes as well, with improvements of A1C around 1%. And GLP-1s, we have very similar data as well. So I would say the problem with this is we don't quite yet know for GLP-1 data what happens when you stop the medications, right? Especially if they're not among diabetics. Do these comorbidities come back? I mean, tirzepatide, which is a GLP-1 GIP agonist, is the only medication ever approved for obstructive sleep apnea. It's FDA approved. So it's pretty exciting time, and we've seen some pretty powerful data among MASLD or fatty liver. So I think there are definitely opportunities for these drugs to improve comorbidities. We know that. But on the scale of, are they improving them as much as endoscopic and surgical opportunities? I would say no. But again, endoscopic and surgery may not be right for every patient.
I'm sure you want to jump in here, Dr. Thompson, because I know you did a major study showing an impact on diabetes with your procedure. So tell us a little bit more about that.
Well, certainly, you can see an impact in diabetes with ESG, as was mentioned by Dr. McCarty, and we've studied this with ESG, with intragastric balloons, and with other devices. And you can expect, a 1 point drop in A1C pretty consistently among pre-diabetics and diabetics, which is fantastic, right? So we think that's helpful, and it's clearly having a downstream metabolic impact, and that it might be just from the weight loss, but it could be from from other mechanisms we're not aware of. However, now we're actually developing endoscopic therapies to particularly that target diabetes directly, right? So there's different ways to do it. One of the early ones was magnetic anastomosis, where we bypassed segments of the small bowel. So similar to what a gastric bypass does. You're trying to reroute food away from that foregut, so you want to avoid the duodenum, which we think the duodenum is not well in obesity or in diabetes for that matter. You know, the small bowel is one cell thick. You're relying on a healthy microbiome and a nice mucus layer there, and your tight junctions. And if that starts breaking down, you get inflammation, and then that can be tied to things like insulin resistance, and it's a slippery slope into obesity and diabetes. So we know it's an unhealthy organ, and we think that's really a part of the mechanism behind which people develop obesity, and in some cases type 2 diabetes. So some of these devices are targeting that. So one of the very early devices was a liner, like a sleeve that you would put in the duodenum, and it was anchored at the duodenal bulb. And that had very encouraging results. You know, you can get 2-point drops in A1C there, and you can get substantial weight loss with that device. So we felt like it had, in the way we describe it as foregut and hindgut mechanisms, you saw GLP-1 spike, right, in those patients, which was interesting. So that meant undigested food and secondary bile acids were very active in the distal small bowel and in the colon, where the L cells are that release that GLP-1. And the fact that it was delaying the mixing of food, so you had your chyme coming out of the stomach there, and it wasn't mixing with the pancreatic juice and the bile until that food got out of that liner, got out of that sleeve, and then it could mix. But by then you're in the jejunum. So that's kind of where we see really improved glycemic control, where you start kind of affecting the duodenum. So you'd remove that liner, and the duodenal mucosa was changed, and you seem to get pretty durable results from that. So the device itself had some issues with hepatic abscesses, so it didn't make it through its regulatory trials and whatnot yet. But they made some modifications, and it's back in trials. But other devices and other companies, they kind of thought, okay, there's a mechanism there. Let's see if we can exploit that to help people with diabetes. And then they started looking at ablating the duodenum. So there are several companies that have looked at this, and some use hot water balloons to do it. They'll lift the duodenal mucosa with a fluid cushion, and then they'll ablate it with hot water. Others have used electroporation, and others are using steam. And what they're doing is they're ablating that mucosa to reset it. And they're seeing very similar results from an improvement in A1C. So really strong kind of diabetic results, improvement in glycemic control. But they're not seeing any weight loss. It's kind of interesting. So once you don't get those GLP-1 spikes anymore, and you're not dumping food kind of unmixed. You're not affecting the mixing of food with those digestive enzymes. Then you're losing the weight loss impact, which is kind of interesting. So we're learning a lot, and again, much of it is based on that early research that was mentioned on the gastric bypass.
So, Dr. Ali, I want to move on to another topic. Unfortunately, one of the claims to fame for Southeast Texas is that it's the world leader in non-alcoholic fatty liver disease, or fatty liver disease. And of course, it has long-term consequences. Some of these patients develop chronic liver disease, develop cirrhosis, and of course, they can develop hepatocellular carcinoma. What have been the impacts of these range of therapies on the prevention, on the regression of metabolic-associated liver disease, and in particular on preventing metabolic-associated fatty liver disease from progressing to more severe forms of liver disease?
Yes, so that's really important. A lot of times I get referrals to my clinic, not for weight loss, but for obesity conditions, and MASH or fatty liver disease is one of the big diagnoses that patients come into my office with. Now, whenever they come, I always tell them the spectrum that you just mentioned, from healthy liver all the way down to cirrhosis. But through our body composition, we are currently doing a study where we can have a predictive model on which patients could be higher risk for developing visceral adiposity and organ damage, one of which would be fatty liver. And a lot of times, if we see that they have a higher risk factors for that, we get abdominal ultrasound, followed up with an MRI if we need it. But if they were to pursue surgical intervention, we oftentimes advocate to get a biopsy. In that biopsy, oftentimes, I not only find fatty liver, but sometimes I find fibrosis. And then we get our hepatology colleagues involved as well, where they may start medications like Rezdiffra and other medications for fibrosis as well. So this is where, when I say that when you have obesity, you could have multiple obesity complications from obesity, and that's why you need this holistic team. Like a hepatologist might not be involved with someone else's care, but they are with that patient. There's also studies going on, which are also performed at Houston Methodist, in terms of GLP-1s and their degree of improvements on patients with liver disease. I know Novo Nordisk and these pharmaceutical companies, they're trying to get FDA approval to have these GLP-1 drugs be covered for these diagnoses. That is one of the biggest obstacles that we as providers have, is how to get access to therapy to our patients. Because we know that if they have a substantial benefit, the insurances may not approve it if the patient is not diabetic. But we know that Wegovy or Ozempic, they have cardiovascular FDA approvals.
Right.
Whereas Dr. McCarty mentioned, Zepbound or Mounjaro can have OSA FDA approval. So there's slowly, with more research, we're getting these obesity conditions approved for therapies that were previously only known to be for weight loss.
Yeah.
So in terms of endoscopic procedures, can they impact on fatty liver disease?
Yeah, great question. I would say yes, definitely. I would say we talked about the progression, right? Obviously, the more degree of fibrosis, the more difficult a surgery or more risk for complications with the surgery, right? Any intervention, yes. But I think specifically for these patients who are higher risk, GLP-1 medications, which there was just a nice trial with semaglutide that showed the improvement in fibrosis, actually, which is sort of the holy grail. And ESG in a select population, maybe with less risk for decompensated cirrhosis, are very viable options. So I think if we can see improvements in aminotransferase levels, we can see improvements in portal pressures. Dr. Thompson and Dr. Gerapino at Brigham and Women's have shown with endoscopic sort of sleeve gastroplasty with a different modality, or endoscopic gastric remodeling as they call it, improvements in portal pressures, decreasing by about 50%. And so while we don't have fibrosis data yet, I think it's coming, because obviously we know if you can get a 10% weight loss in these individuals, it's been shown that that's enough to improve or reverse fibrosis. So I think we've got some pretty powerful endoscopic data. It's small, but I think it's only going to continue to grow as we continue to push the boundaries of what's possible.
Now, one of the things you've all said, and I think you're not just being nice to each other, is that combination therapy is probably going to be the future here. And I'd like each of you to, if you like, give an estimate or have a guess as to predict as to what this will look like over the next 5 years. I know that's a very hard thing to do, but Dr. Thompson, how do you see the medications, the lifestyle, the endobariatrics and surgery working together, if you like, in the future? Are they going to be used as steps from one to the other, or are they going to be used in combination? What do you see happening?
I think that, it'll depend on the patient. I think the personalized approach is going to be critical. And some patients might benefit from a solo therapy, others might benefit from combination, and others might benefit from sequential therapy, right? And planning it out. And we're already kind of seeing that. We just need kind of to understand the patient's phenotypes better. And I think that work is coming along with the help of AI and other technologies starting to incorporate body composition, as was mentioned. I think that we're going to have a better understanding when you put all these things together. Do they have diabetes? What's their body composition? Do they have sarcopenic obesity? If someone has sarcopenic obesity to begin with, they shouldn't be on a GLP-1 at all, right? So I think we're starting to understand this a little bit better. And so as we get more information and people start collaborating more, which I think is great, I think that now people are seeing the value in the medicines more and the value in endoscopy more, and surgery has always been valuable. So it's nice that we're all kind of getting sort of on an equal playing field and finding our niches. But I think what's quite interesting is combination therapy within procedures, which we haven't talked about much, but you see an endoscopic therapy or a medical therapy is separate, but this next generation of procedures are combining these things, right? So we're doing targeted gene therapies now, where we have an endoscopic procedure, endoscopic ultrasound, where we can place a needle into the tail of the pancreas and inject an adeno-associated virus into that tail, and then it will alter the beta cells so they can produce their own GLP-1. So now this really is potentially game changing, where you're doing these kind of device, kind of procedure medication combos, where we're having a permanent effect after one injection. It's like taking a one-time injection of a GLP-1 to last the rest of your life, right? So those are just getting into clinical trials now, and it's very exciting.
That's endopharmacology.
Yeah, you coined it. There you go.
That's right. So, Tom, where do you see, from your point of view as an endoscopist, where do you see your endoscopic techniques fitting in this equation in the future?
Yeah, I think when these GLP-1s first came out, there was a little bit of an adversarial component, right? You were either medications, endoscopic, or surgery, and that has really changed to this holistic sort of approach, which I think it needs to be embraced. But I think, we've got oral drugs coming in the pipeline, so the drugs are certainly not going away and something we need to embrace. Again, I think it's based on individual patient preference right now. I think phenotypes would be fantastic if we were able to predict who would respond to what.
Or where that trajectory was going to be.
Where that trajectory would be. I think that's the best part. I think cost factors wise, endoscopic procedures are probably the most cost effective along with surgery, especially compared to these GLP-1 medications. But these medications are not going anywhere. They're only going to get more popular, especially and lower in cost, especially as these newer drugs come out with even better weight loss numbers.
So, and from everything you said so far, Dr. Ali, you clearly are an advocate for combination therapy.
Yeah.
You've clearly been at the leading edge of a lot of these procedures. Where do you see surgery heading in the future? Is it going to be the last resort, or as Dr. Thompson mentioned, are you going to be selecting patients really from the get-go in whom surgery is obviously the best choice, rather than waiting to try this and try that and try something else?
So as you mentioned, my background is in surgery. About 4 years ago, I predicted that for my patients, I wanted to offer them all the modalities that I could potentially do. It's because I did not feel that it was fair to my patients if I could only offer them the surgical therapy model. I wanted them to offer all 4 models of weight loss therapies. And sometimes I've realized in the course of my practice, many of the patients, they need more than one, okay? I've also done combination therapies where I find it very hard sometimes to revise the gastrointestinal anastomosis because of the patient could have 4 or 5 surgeries in that area. So I do that portion of the revision endoscopically by doing a TOR. And then if I want to do limb lengthening procedures or other procedures, intra-abdominally, I do that as well. So I'm using different modalities within the same patient at the same time. And I find that before there was some apprehension that with these GLP-1 drugs that surgical volumes would dip and surgeons were against it. I'm actually on the opposing side of this. I think that the advent of these new therapy options, including medical GLP-1s, they've actually introduced a whole cohort of patients that would have never come to see me. And when they walk through the door, it lets them get access to me, and I can actually educate them that, hey, you want weight loss, but what I want is to resolve your obesity conditions that you have, right? And just talking to them, it opens up a whole avenue of different therapy models. And I think because of that, we are able to have more access to more patients. And of course, the prevalence of obesity is increasing year over year. 20% of kids, adolescents are now obese. And when they become adults, it's only going to increase. So we need access to patients, and patients need access to all of these therapies as well.
Now, one of the things we haven't discussed, and it bears on something that was mentioned, namely cost. We're talking about this in the context of the United States, which is a very wealthy country. There are many countries in the world where they're also experiencing an epidemic of obesity, but obviously do not have access or cannot afford these drugs. So in those parts of the world where obesity, diabetes, metabolic associated fatty liver disease are really becoming epidemic, and I'm including here several African countries, what are the best options for them? Will endoscopy and surgery be a better option in these parts of the world until GLP-1s become cheaper? Dr. Thompson?
That's tough, right? Because this skill set is very hard to acquire, right? I think surgery, doing a sleeve gastrectomy, in my opinion, is easier than doing an ESG properly or doing a TOR, right? And so the learning curve is very long, and it's been established that it's a long learning curve. So I'm worried in this country with the enthusiasm for these procedures where people think they can do a weekend course or two and then do the procedures adequately. It makes me very anxious as we see them spread. There's over 360 physician providers on the Boston Scientific's kind of physician locator right now. Not all those people are qualified to perform these procedures. To be able to get on the physician locator, you have to have done 10 procedures. And we've recently run a course, a STAR program course within the ASGE, that's American Society for Gastrointestinal Endoscopy, where we're making sure these are being adequately trained. And we've taken only people that have already passed the other courses. They had to pass the other suturing courses to get into the bariatric course for learning ESG. I'm very anxious about that, especially for the endoscopic procedures. So I think that perhaps in those countries it's better if you already have skilled surgeons that know how to do laparoscopic procedures, to just expand access to the existing procedures that are available. And then, hopefully as semaglutide is coming off patent in many places, in Canada coming up soon and in other places as well, hopefully that'll drive those costs down. We already know that the cost of the GLP-1s are considerably lower in other countries, but I think that there's probably a combination of that, and then endoscopy should be introduced a little more slowly so we can do it safely, because it is definitely a different skill set. Flexible endoscopy, the surgeons do more laparoscopic stuff, so they're not going to pick up on it very quickly, and GI doctors do a lot of colonoscopy, and that's not really therapy, so they're not picking up on it quickly either. So it's this unique middle ground of people that play in the sandbox that we're in here, that can do these procedures. And I just think it's we have to scale it very carefully, and that's going to take a few years until, or if we have easier technology, technology that's a little quicker to learn and safer. I think that's on the way with some other things that are automating the process, and then I think it's going to democratize it. But right now, the procedures that are approved are very technically demanding, and it's concerning to not have a backup network, if you will, in these other countries. So I think it's going to be a long process.
Well, I've learned an awful lot from this discussion. Maybe I came in with a lower fund of knowledge than I thought, but I certainly have picked up on a few very important points. And several of them were actually mentioned by Dr. Thompson there in his last contribution. One is looking to the future, the possibility that we will have individualized therapy, which I think is very exciting, that a thorough evaluation of the individual patient's phenotype may lead to more directed therapy and more successful therapy, and that's very exciting. The other important points that have come out is the importance of giving options to patients, laying out all the options that are there, giving them the data or the best data available on what the outcomes are likely to be, and engaging them in the decision process. I think that's very important. And the third point I'm making, again, I would emphasize what Dr. Thompson just said, is the importance of having skilled individuals doing these procedures, because that ultimately will determine the outcomes. So I want to thank our panelists for being with us today, and Dr. Thompson for joining us from Boston. I think it's been a wonderful discussion. As listeners, we hope this has been an informative and enjoyable discussion, and that you may take a few important points away from these discussions which will help you in your clinical practice. And of course, we look forward to feedback from you and to being with you again in one of these discussions in the future. Thank you all very much.